Thank you. I just want to thank Dr. Sundeep for inviting me, Dr. Mehta and Dr. Verma for helping organize this event. I think it's an excellent opportunity for us to share our knowledge and all learn and grow. Excuse me. Today I was asked to talk about pediatric obstructive sleep apnea, so that's what I'll be doing. I don't have any relevant conflicts of interest to disclose. In terms of the objectives, what I'm hoping to do is through the use of illustrated cases.
Yeah, that's just your thing. There's nothing there.
The audience members, I'm hoping will gain a working knowledge of the nomenclature used in. Oh, we've lost it. We've lost the screen here.
Ollie. I threw it.
So yeah, hoping to get the audience to have a working knowledge of the nomenclature used in pediatric sleep medicine, particularly emphasizing and highlighting the differences from that used in adult sleep medicine. Appreciate the clinical presentation of OSA in pediatrics. Understand the pathophysiology of pediatric OSA. Have an approach for managing children with OSA and understanding when to pursue further evaluation. Have an approach to managing children with OSA, including, and have a knowledge of various therapeutic options and how to select what may be the most appropriate therapy for a given child. All right, case one. So the first case is a 1-year-old previously healthy patient who's referred for assessment in regards to snoring. No improvement with nasal aspirator. We're getting a bit of feedback. Is it possible to move this? Because I can't.
No, the system just went out.
Yeah, it's not too bad. Sorry about that. We were just trying to figure out how to best position the microphone with the speaker. So case one. So 1-year-old previously healthy. In terms of the HPI, comes in with 3 to 4 months of snoring, slightly improving over time. No witnessed pauses, no gasping, and no choking sounds. The parents did describe that he had a previously noted inspiratory sound in sleep. It was unclear if this was stridor, but they say that's now resolved. On exam, well appearing, normal vitals, room air oxygen saturation is normal. I wrote normal-ish growth parameters, and that's because his weight was between the 2nd and 5th centile. We don't have previous weights to compare. So sometimes in pediatric OSA, you'll see children falling off of their growth curve. So if he was the 25th centile prior to me meeting him, and he's now at the 2nd and 5th, he's actually failing to thrive. He's lost a significant amount of weight. But if he's always been between the 2nd and 5th, then maybe he's just a small guy. No previous weights were available, so it's difficult to know. In terms of his head and neck exam, he had grade 2 tonsils, mild nasal congestion, overall challenging exam. Cardiovascular and respiratory exams were unremarkable. So in terms of next steps, the question would be, send him to ENT, do we arrange a sleep study, do we do an overnight oximetry, give him intranasal steroids with montelukast and follow up in 3 months. These are all different options. And before we go back to that case, so we'll circle back, but I just want to make sure that we're all speaking the same language and nothing gets lost in translation. This is a picture I took of a sign that was for a hair salon when I was abroad, and the sign read hair virus, which I'm sure it was not meant to read. So that's what we just want to make sure we're all using the same language. So in terms of nomenclature, I don't think I need to tell the audience what apneas and hypopneas are, but I want to highlight the key differences between pediatrics and adult events. So in terms of obstructive and central apnea, I mean, we all know that an apnea is a cessation of airflow, or at least a complete near cessation of airflow. Obstructive, you've got respiratory effort, and central, you have no respiratory effort. The major difference that I've underlined it here between pediatric and adult classification for these events is the duration criteria. So the duration criteria in children is a minimum of 2 breaths duration, and that's from trough to trough when you're assessing on polysomnography, versus adult where you're looking at a 10-second minimum duration. So that's important because you may be missing events if you're not using these criteria. And then, as you know, in obstructive events, you've still got the presence of respiratory effort. For central apneas, the duration criteria in children is more than 20 seconds, or it's 2 breaths duration, and there's an associated desaturation or arousal. And practically speaking, it's quite uncommon to see a duration of 20 seconds without an associated desaturation in children. And again, for essential apnea, there's no respiratory effort. For a mixed, again, it's the duration that's the difference, and that's 2 breaths. And the other difference in pediatrics versus adults is that for a mixed apnea, the order of central obstructive is not relevant, so it can happen in either order.
The same thing is for adult also.
Is that
3 and 0? Same thing in adults.
excellent? So I'm not up to date with the adult criteria, but that's good to know. In terms of pediatric hypopnea, so again, this is the same 30% reduction in flow. The duration, again, 2 breaths is the minimum duration, and then associated 3% desaturation or an arousal. For hypoventilation, so if you are measuring CO2, you're using either an end-tidal or a transcutaneous as a surrogate of your arterial CO2. And in pediatrics, we would mark it as nocturnal hypoventilation if the end-tidal or the transcutaneous is above 50 for about 25% or more of the total sleep time. The adult criteria is a little bit different. So if it's above 55 for an absolute duration of 10 minutes, or if there's a 10 millimeter increase from the awake baseline for more than 10 minutes, such that the value is above.
نعم. في محاضرة بتفرج عليها أروح أنام دلوقتي.
Okay. And then periodic breathing. This is not something that I think is used in adults. We don't see chain strokes breathing very commonly in pediatrics, but periodic breathing we will see in younger children, not infrequently. And this is essentially when you have a series of central apneas or central pauses. So they don't need to meet the apnea criteria with the desaturation or the arousal. But if you have a central pause for 3 seconds or more, separate, and then a series of at least 3 of them separated by no more than 20 seconds of normal breathing in between, we would call that periodic breathing. We all know what an AHI is. So the total sum of apnea and hypopnea is divided by the sleep time to give you a numbers per hour index. And so, you know, when we talk about sleep studies and the question comes up of like, what is the information that we're gleaning from it, right? And I feel like, you know, for a lot of people, maybe not everybody, but for a lot of people, we're looking at the obstructive AHI, the obstructive AHI, the obstructive AHI, maybe the central AHI. But there's a lot more information. I mean, you guys all set up these studies and or interpret them and use them clinically. And I think it's important, you know, when I'm talking to trainees and other healthcare providers who don't have expertise in sleep medicine, to know that there are other metrics that are quite useful that we gather from a polysomnogram. And so the percent total sleep time with an oxygen saturation less than 90% is also quite relevant. The oxygen saturation nadir is important. The mean oxygen saturation in sleep is important. The CO2 peak and the percent total sleep time with a value above 50 is important. And these are all things that may not be captured by the AHI. And so I think it's important to know that there's additional information. I think part of the reason why the AHI gets emphasized so much is because that's what we use for severity classification. But certainly you could argue that not all AHIs of the same number are equal in terms of the degree of hypoxemia being a very relevant metric. In terms of severity, so I think this is very relevant. Severity classification is quite different in pediatrics. So again, based on the AHI, if you have less than 2 events per hour, we generally consider this to be a normal AHI. 2 to 5 events per hour is considered mildly elevated. 5 to 10 events an hour is considered moderate. And then more than 10 events per hour is considered severe. And so this is generally used for children 12 years of age and younger. At 13 years of age, up to 18 years of age, you can either continue to use these criteria and the pediatric scoring criteria, or you could switch to the adult criteria based on sort of best practice from the AASM recommendations. And if you contrast this to the adult severity classification, you can see that mild, moderate, and severe are all encompassed within mild for the adult numbers. So less than 5 being considered normal, 5 to 15 mild, 15 to 30 moderate, and then more than 30 severe. So it's very different in terms of classification scheme. In terms of epidemiology, pediatric OSA is common. So when you think of medical conditions, a prevalence of 1 to 4% it's a common condition. Excuse me. And that's in healthy children. It's important to know that in at-risk populations, so children with trisomy 21, the prevalence can be quite high. It can reach 60 to 80%. In children with other syndromes, craniofacial syndromes, the incidence can also be quite high. So 1 to 4% in the generally healthy populations, and then in particular conditions which are not uncommon, the incidence is extremely high. The peak prevalence, so historically, when we think about the epidemiology of pediatric OSA, the peak tends to occur between ages 2 to 8 years, and that's when you have a peak in adenotonsillar hypertrophy. But over time, we've seen that the epidemiology, rather than having a single peak between 2 to 8, there seems to be a bimodal peak. And that's related, at least in parts, to changes in body habits that we're seeing in children and adults. And so you have this second peak associated with increased weight. And so when we think about different phenotypes of pediatric OSA, there's the classic phenotype, so that's related to adenotonsillar hypertrophy, and that's the one that peaks between 2 to 8 years. And then there's this more obese adult-like phenotype, and that peaks in later childhood and adolescence. Of course, there's overlap. You may have children that have both obesity and adenotonsillar hypertrophy. And then you've got this third type, or this third phenotype. This classification scheme comes from the European Respiratory Society's sort of arbitrary classification of children in terms of OSA clinical presentation. So they use less than 2 years of age as what they call this congenital phenotype, with craniofacial, neuromuscular, and/or genetic risk factors. Practically speaking, I would say generally this applies to children less than 1 year of age. Between 1 to 2, you certainly can have the adenotonsillar phenotype. In terms of clinical features, so you can separate this into nocturnal and daytime symptoms. And it's important to know that caregivers infrequently volunteer symptoms. If you look at the literature, that's certainly what's reflected. I think over the last, I'd say 10 to 15 years, that's changing. I think parents are more in tune with the importance of sleep and sleep health in terms of how it relates to day-to-day function. And this is, I think, at least in part related to sort of the access to information that we have. But in terms of the importance of screening, I think it's important to know that parents may not offer these symptoms. And oftentimes when you do chat to families, when they do show up, they'll say, yeah, I thought it was normal that they snore. And it's not seen always to be a problem. So it's important to screen for that at routine health visits. In terms of nocturnal symptoms, I feel like these are pretty intuitive. Snoring, loud breathing, pauses, periodostal breathing or labored breathing in sleep, nocturnal diaphoresis. And then these ones that become less sort of intuitive, but sometimes we'll see children take a prone position to sleep, extend their neck, and then nocturnal enuresis, either like delayed primary nocturnal enuresis or secondary nocturnal enuresis can certainly be seen in OSA. In terms of daytime symptoms, so you have your physical symptoms. So waking up with a dry mouth or open mouth breathing, morning headaches, poor appetite. And then you've got your neurocognitive symptoms. So you've got, I put in quotations, ADHD-like symptoms. And that's because it's not necessarily that they meet criteria for a diagnosis of ADHD, but they will present with similar symptoms with respect to inattention, executive dysfunction, mood lability, daytime fatigue, learning difficulties, academic difficulties. Excessive daytime sleepiness is quite unusual for children. Usually they're the opposite, they're quite hyperactive. In terms of physical exam, so you want to complete a full exam, including growth parameters, because that would be relevant on both ends of extremes, so either obesity or failure to thrive. Head and neck exam, I think, is really where the money's at. Looking for risk factors for OSA, so tonsillar hypertrophy, craniofacial anomalies, so a small chin, a recessed chin, a large tongue, mouth breathing, assessing nasal airflow so that they're very congested at baseline, oropharyngeal crowding, so we assess that by way of Mallampati, turbinate assessment, assessments of the nasal septum for deviation. So this is all very important in terms of your anatomic risk factors for OSA. In terms of making a diagnosis, I think it's pretty straightforward. If you've got symptoms and you've got a sleep study that's consistent with OSA, then you've got pediatric obstructive sleep apnea. The challenge really comes with, polysomnography being available, and so, and this is part of the reason that this is such an important thing that we're doing today is just increasing awareness and resource availability for children to access polysomnography. I think in Ontario, in the GTA, is probably the most accessible area for pediatric polysomnography, but it's not like that in the rest of the province, and certainly not the rest of the country. So, when you've got really long wait times, then you're sort of stuck with other options. Your clinical history is quite limited, so just assessment by way of symptoms or questionnaires is not very good at predicting sleep study findings. And when you take a look at the clinical history combined with the physical exam as done by pediatricians, pediatric respirologists, or otolaryngologists, the positive predictive value, so the ability of them to say, yes, this child's going to have clinically significant OSA is about 60%. That's like a touch better than flipping a coin. Validated questionnaires, so the pediatric sleep questionnaire, the OSA 18 are also quite limited. They've got about a sensitivity of 70%. If you look at, it will vary from one study to the next, but when you look at meta-analyses, it's about 70%, and a specificity of about 30 to 40%. So they're not great from a diagnostic perspective. Overnight oximetry is limited. So if you've got an oximetry it's very helpful when it shows you a classic pattern, but it can be falsely reassuring if it looks normal or not terribly abnormal. And then it is, if you use a combination of all of these things, that may be very reasonable in a resource limited setting. In terms of OSA pathophysiology, so there's I think it's the easiest way to think about it, these two different components. So if you look at the anatomy, there's like reduced airway caliber. So this can be by way of excess lymphoid tissue, so big tonsils, big adenoids, lingual tonsils, craniofacial factors that we've already talked about, so small chin, a recessed chin, a large tongue, a tongue that tends to fall back, and then increased weight just by the mechanical compression of the airway. And also, we know that children with an elevated BMI will also have increased fat deposition in the soft tissues around the airway. And then airway collapsibility. So you've got your anatomy, so the structure of your airway, and then you've got like the risk of your airway to actually just collapse down and obstruct itself. And so the peak crit, which I don't think we'll spend too much time in, is basically the pharyngeal pressure at which you're going to get airway obstruction. That's like a global measurement of your collapsibility. And your collapsibility is determined by neuromuscular inputs into the upper airway and alterations in this input. So we've got motor inputs into these pharyngeal dilator muscles that sort of maintain our airway patency. And so that can be altered in different conditions, which increases the risk of your airway sort of collapsing down and obstructing. And then you see this in conditions like increased collapsibility, also in conditions where you've got low muscle tone and neuromuscular disease. And then if there's increased weight centrally, when you lay down, that pushes your abdominal contents up. And it's sort of, if you think of your airway as like a collapsible tube that's hanging when you're standing up, when you lay down, if you've got increased weight pushing your abdominal contents up, you sort of lose that tethering effect that you have with gravity when you're standing up. So increased weight, elevated BMI plays a role both in the airway caliber and in the collapsibility of the upper airway. So when you have a combination of these two things happening, you get obstructive sleep apnea. What's really challenging is in the context of someone who has multiple elements at play, you don't really know what the relative contribution of any of these things are. And so you have to take a stepwise approach in addressing them. So reduced airway caliber, I think we've already sort of spoken about this. And this is just like a very good sort of visual of what you're going to be thinking when you're looking at anatomic things. And when you look at this sagittal view, you can really see all the different sites. So you've got I don't think my cursor doesn't show up here, but essentially anywhere from the nose to the vocal cords, you can have some level of obstruction. So you can have nasal obstruction with turbinates, mid-face hypoplasia, so if your mid-face is recessed, a small airway, retromicrognathia, so if your chin is recessed back and small, tonsillar hypertrophy, a big tongue, or a tongue that tends to fall back, and then adenoid hypertrophy. All of these things can be risk factors for OSA. And then airway masses or tumors, also something relevant to consider. In terms of collapsibility, we sort of chat about that. I don't want to get too deep into this, but basically, your peak crit or is the pressure in your pharynx that at which point you're going to obstruct, right? And so, if you think of your airway as like a rigid tube on one side, and you've got your nose on one side, then you've got your pharyngeal space on the other side, and then distal to that or downstream to that, you've got your trachea. If the pressure in your pharyngeal space is exceeding the pressure in your nose, you're going to have collapse of the airway. And in children with OSA, we know that peak crit is higher. So what that means is, generally in children, to have collapse, you have to generate very high negative pressures. So negative pressures in the order of like -25. But in children with OSA, you don't have to generate such a high pressure. They will have tissue collapse at much less negative pressure, so between -5 to 0, and sometimes even positive. So that's something that we do see in OSA if you were to measure that, and it's telling you just how collapsible that airway is. It doesn't tell you why that's happening, it just tells you that it's more collapsible. Let's skip this for now. So why should we care? So why should we care about pediatric OSA? What are the concerns or the impact on the child? So these are the different sequelae of OSA. So there's neurocognitive sequelae, and that can affect many domains of cognition. It can affect working memory, attention, language, executive function. There's also academic achievement. So we know that they do less well academically. Failure to thrive, so weight gain or the inability to gain weight is important. Cardiovascular implications. So with intermittent hypoxia while you sleep, that can have an impact on your pulmonary vascular bed, and that can result in pulmonary hypertension. It's not common, but it's certainly something to be aware of, and it is increasingly common in certain at-risk populations. Systemic hypertension. So with intermittent hypoxia, increased arousals through your sleep, you do get an upregulation of your sympathetic nervous system, and that can increase your risk for developing hypertension, as well as increased systemic inflammation, putting you at risk for hypertension. And then metabolic sequelae. So in the context of children where they've got an elevated BMI, untreated OSA is an independent risk factor of developing insulin resistance, and it is also an independent risk factor for developing fatty liver disease. So back to the case. So 1-year-old snoring, persistent nasal congestion, and grade 2 tonsils. So what did we do? We talked about ENT referral, sleep study, O&O, and just trying to treat with nasal steroids and montelukast. We ended up doing an ENT referral, an overnight oximetry, and a lateral neck x-ray. So the lateral neck x-ray can be useful for looking for adenoid hypertrophy. So you can see here, this is pointing at the adenoids, and this right here shows you how to measure and assess the adenoids in terms of quantifying the degree of hypertrophy on a plain film. It's not the best test. An otolaryngologist doing a scope is probably a better assessment of the adenoids. But when it is helpful is when they are obviously enlarged. And so here, if you look at the red line, that's basically a line along the basal aspect of the occiput. The white line, A, is the maximal sort of point of adenoidal tissue. And then the line N is your nasopharynx, and the P is your palate. So if you make a line perpendicular to that red line for the adenoids and for the nasopharyngeal airway, you can get an estimate based on how much of that space are the adenoids occupying for how large they are. We also did an overnight oximetry. So this is important. It speaks to the limited access to polysomnography. So this is a 1-year-old child, so we can't do the sleep study in the community. And getting an oximetry is much quicker than referring to a tertiary care center for sleep study. So for him, the oximetry was quite useful, and some relevant parameters that came out of this, I mean, this is textbook in terms of 8.5 hours of data collected. We got an oxygen saturation in here of 64%, and you can see that the total time spent with a saturation less than 90 is 3.3%, which is significant. And the oxygen desaturation index is 48 events per hour. And the presumption here in this child's clinical context with symptoms consistent with OSA and adenotonsillar hypertrophy is that these events are related to obstructive respiratory events, hypopneas or apnea. And you can see that they cluster. So we do know that OSA in both pediatrics and adults tends to occur more so in REM sleep when you're sleeping with atonia. And you can see that there's these concurrent increases in the heart rate. So we've got this classic pattern of episodic desaturations with increase in heart rate in the context of clinical symptoms. So this goes back to the challenges of making a diagnosis without access to polysomnography. So if this ONO is normal, it doesn't mean he doesn't have OSA. It's just very helpful when the ONO looks like this, the clinical story fits, then you really, essentially clinically made the diagnosis. So for this child, we reviewed the oximetry, and now on retrospect, when the family knows what to look for, they're reporting, you know what, he does actually have occasional pauses and gasping sounds in his sleep, but oftentimes families aren't watching their children sleep. ENT referral was made, and they were updated with the oximetry results. The child had surgery within a month. Post-op generally did well, but did require some blow-by oral steroids, was discharged home on high flow, which Dr. Verma, I believe, was talking about later, recovered well, and eventually that was discontinued. So in terms of a summary for this child, it's a young child with minimal symptoms at the time of initial consultation, but the imaging ONO was consistent with OSA, as was the follow-up clinical visit when the family now was reporting increased symptoms. Responded well to the first-line treatment for severe OSA, which is adenotonsillectomy. And so that's really about it for him. In terms of OSA treatment options, so we generally look at this based on severity classification. So for mild OSA, pharmacologic therapy is not unreasonable. So that would be using intranasal steroids or montelukast, and both of those can reduce the degree of adenoid hypertrophy in the context of OSA. And then if weight is a concern, then weight management is always important consideration for OSA management. For moderate to severe OSA, in the context of adenotonsillar hypertrophy, that would be considered first-line therapy. PAP therapy, so CPAP or BiPAP, is also a reasonable option. And then again, if that's a concern, weight management is always a consideration. And then there's other options beyond that. So high flow nasal cannula therapy, positional therapy, something that I know the adult sleep docs are quite familiar with. It's not something that's used often in pediatrics, but certainly is trickling down. Orthodontic or dental procedures and devices, not commonly used. The literature in regards to this, so for mandibular advancement, there's very little literature that I'm familiar with. For a maxillary expansion or a maxillary expanders, there's very small studies looking at benefits, which seems to be modest. And then advanced surgical options, and we'll chat a little bit about that later. So case 2, 7-year-old, previously healthy, referred for snoring and witnessed pauses and bleeding, has tonsillar hypertrophy, grade 3 tonsils bilaterally, on a plain film has adenoidal hypertrophy. Sleep study is obtained, and the overall obstructive AHI is 38 events per hour. The child's referred to ENT, has adenotonsillectomy, has a sleep study 4 months later, has persistent severe OSA. The overall obstructive AHI is 20 events per hour. So he's referred back to ENT clinic. They do another nasopharyngoscopy while he's awake. No clear site of obstruction, no adenoid regrowth. The child is non-obese, has no craniofacial concerns on exam, and is non-syndromic. So what do we do now? Do we consider a trial of CPAP? Do we do neuroimaging? Do we do an EEG, or do we discharge him to his primary care provider? I think we can all agree that. What's that? I don't know if someone said something to the audience. So I think a trial of CPAP would not be unreasonable to treat the OSA, but the key here, I think, is just to know that if you have a child who has OSA and you don't really know why they're doing it, it's important to try to figure out why it's happening. A healthy child with no clear risk factors or no explanation for the OSA shouldn't exist. Like we should be able to look, or we should be able to find something. If you can't, at least you've done your due diligence when you've looked. So the airway was clear. So the next step would be looking at whether there's any neuroanatomic considerations. And this
youngest age the child can use CPAPs 2 years old?
I mean, that's a tricky question. So in terms of, there's no absolute youngest age. So you, like for CPAP as a technology, you use that in the neonatal intensive care unit for premature babies, right? So there's no youngest age for application of CPAP. For use in obstructive sleep apnea or sleep disordered breathing, again, no absolute youngest age, but some considerations would be like feeding challenges if you're using CPAP in terms of sleep schedule. So for infants, it can be very difficult for infants who are sleeping 18 hours a day to effectively use CPAP. So 6 to 12 months is probably the youngest I've seen it used. But certainly you can use CPAP as a technology, but for like sleep disordered breathing management at home, it just becomes practically difficult in younger children.
Because even adults don't want to use CPAP on the child.
So an infant will tolerate it because they're right. So then when you get into toddlerhood, it becomes very challenging. Yeah. So in terms of this case, so red flags, you've got a young child who's non-obese, non-syndromic, and their airway is clear, but they're still having persistent obstructive sleep apnea. In terms of the MRI brain, so with this patient, a Chiari-1 malformation was seen, and that's, we'll talk about what that is. That's basically a descent of the cerebellar tonsil. So I don't have like my cursor doesn't show up on the screen here, but here you can see in a Chiari, you've got descent down here of the cerebellar tonsil, which when they go down below the foramen magnum, you get compression of the brainstem and the respiratory centers. And so a Chiari decompression surgery was done for this child. Oh, thank you. Where you basically take out these small pieces of bone to open up that space to remove any pressure on the cerebellar tonsils. And so Chiari malformation, sleep disordered breathing. So this is something that we've seen increasingly in children, that in the context of a Chiari malformation, you can have sleep disordered breathing, both obstructive sleep apnea, central sleep apnea, or a combination of both can be seen. And the frequency with which this is seen is quite high. These studies are small studies, so it's difficult to know. And these are all children who are known to have a Chiari malformation. So it's not that we're looking at children who present with sleep disordered breathing that's not yet explained, and then we see how many of them have a Chiari. It's kind of the opposite. This is children who were diagnosed with a Chiari for whatever reason, and then they look at those children and see if they've got sleep disordered breathing. And these are just 3 samples of different studies that have been done. There's been more that have been done over the past few years, but the incidence is about 20 to 40%. And again, like I said, that could be obstructive, central, or a combination of both. So what I was saying is it can be obstructive sleep apnea, it can be central sleep apnea, or it can be both. And so for central sleep apnea, I think it's intuitive why that's happening. If you've got pressure on the respiratory centers, you may have issues with signaling normal respiratory pattern generation. And so central sleep apnea makes sense when you've got something happening centrally, right? In terms of obstruction, I think that's less intuitive why that might be happening. And it goes back to what we were chatting about with airway collapsibility. So you do have from the medulla, you've got motor input to the pharyngeal walls. And so when you've got compression on the medullary centers, you may have loss of motor input to the pharyngeal muscles. And so that could decrease pharyngeal tone and increase that airway collapsibility. So that's what may be putting you at risk for OSA in this context. And also, we all have a reflex when we generate a negative pressure during inspiration, a reflex that negative pressure causes an increase in the pharyngeal dilator tone. And so it's possible that there's also a blunted reflex there. Both of those things are going to contribute to increased airway collapsibility and increase the risk of obstruction. Does that make sense? Oh, that should read case 2. So we do a repeat sleep study after the decompression, and the child now has mild OSA, so the HI was 2 events per hour. So really, I would say a success in terms of going from 38 to 20 to 2. So persistent and severe OSA, who's at risk? So things to consider, the first would be adenoid regrowth. So if you've got a child who has pediatric OSA, severe, has surgery, and then you do a post-op study and they've still got OSA, but you wonder if the adenoids have grown back. So that's the first thing. And so you would want an assessment of the airway to see if that's happening. Obesity, so that's for sure a risk factor. So that would be a pre-existing, sometimes, risk factor for persistent OSA. And we also know that children after adenotonsillectomy do have a tendency to increase weight. And so if they've developed that post surgery, that's a factor to consider. Underlying craniofacial risk factors. So earlier I was saying it's difficult to know what the relative contribution is of all these different things if you've got multiple different things happening in the same child. So if you do have other craniofacial risk factors, so microretrocathia, or the easiest population I think to conceptualize this in is in children with Down syndrome. So in Down syndrome, children tend to have a larger tongue, and that tongue tends to fall back when they sleep, and they've got low muscle tone. So they've got multiple reasons to have OSA. So if they have got adenotonsillar hypertrophy and severe OSA, you'll still look at taking their tonsils and adenoids out, just recognizing that they are at risk, at higher risk for persistent OSA post-op, because you haven't addressed these other factors. Hypotonia, and then an alternative airway lesion, so making sure there's not something else. So a common second airway lesion would be, or third, I guess, would be lingual tonsillar hypertrophy, which we also do see in children with Down syndrome post-adenotonsillectomy. And then a central lesion. So this is speaking to this particular case, but when you've got a non-obese child with no alternative site of obstruction, that you can identify, or if there's neurologic symptoms, then thinking about a central lesion would be very important. In terms of how to investigate, so you could do a routine structural MRI. So that's just looking at the anatomy. Cine MRI is a more refined tool where you gather consecutive images over time while the child's sleeping, and you get a dynamic assessment of the airway. So it lets you look at different sites, and you can see what's happening in terms of obstruction. So is the tongue falling back? Is there large lingual tonsils? So when we think about tonsils, you've got your regular tonsils, which are at the back of your throat. That's what's taken out during a tonsillectomy. But then there's another set of tonsils just at the base of your tongue, and that's your lingual tonsils, which generally you wouldn't take out at the same time. And so you can see that on an MRI, on a Cine MRI. And so it helps you look at different levels of the airway to see if there's multiple places where you're having obstruction. The sedation is done with medication that doesn't affect airway tone the way most sedatives do. Or you could do what's called drug-induced sleep endoscopy. So you have the child sleep, again, with dexmedetomidine, and you do an airway assessment, an ENT would do this. And that's very helpful because you can see while the child's sleeping, what's happening to their airway. They give you the same information, but a little bit differently. The Cine MRI, you can see all these different sites and all these different levels at the same time, whereas with drug-induced sleep endoscopy, you can only see one level at any given time, but you get a better appreciation of what's happening concentrically. Different people have different preferences about how they would want to assess. In terms of treatment options, so when you've got severe and persistent OSA, you're looking at PAP therapy or some of these more advanced, or some of these more advanced surgical options. So getting into like a detailed discussion about this would be its own talk, but if you are doing a Cine MRI or a DICE, you will identify particular sites that might be amenable to surgical intervention. So if you've got a large tongue, for example, you can do a tongue-based reduction. If you've got glossoptosis, so basically if your tongue is falling back and obstructing your airway, you can do what's called a repose procedure or a tongue suspension, where you essentially put a screw in the mandible and then you suture the base of the tongue to that screw so it doesn't fall back as easily, but it still gives enough movement so that you can chew, speak. If you've got lingual tonsillar hypertrophy, you can do a lingual tonsillectomy. So if you've got mid-face hypoplasia, certain conditions where you'll see this like achondroplasia, you can do a mid-face advancement. If you've got a small chin that's recessed back, you can do a mandibular distraction and surgically move the mandible forward. And then hypoglossal nerve stimulation, it's not something that's approved by Health Canada for use in pediatrics, but something that may be used or considered in the future. So case 3, how are we doing with time? Oh, doing good. So case 3, 16-year-old presents with daytime sleepiness, chronic snoring, no other witness symptoms. He sleeps in his own room, so he's got no bed partner. So there's not, like the parents are, they don't really want him to sleep, so they can't tell you what causes breathing, choking, gasping. They just know that his snoring shakes the home when he's sleeping. He's very sleepy. He's falling asleep on the bus. He's falling asleep at school. He takes a nap at home 1 to 2 times a day. He had an tonsillectomy as a young child, and his BMI is quite elevated at 42.5. So he comes in and has a sleep study. His obstructive AHI is 132 events an hour. His saturation nadir is 32%. He spends 23% of the night, so nearly a quarter of the night with a saturation less than 90%. He's not hyperventilating, which is great. In terms of next steps for him, so we could offer CPAP, we could do a revision adenoidectomy, and that's if his adenoids have grown back. Look at an oral appliance, positional therapy, or maxillary expansion. I didn't give you enough information to comment on the positional therapy, but I think we can all agree that adenoidectomy, oral appliance, and maxillary expansion are probably not the best option. And so for this guy, we went ahead and tried CPAP. And I don't have a slide showing it, but he actually did quite well with CPAP. He was very compliant. He felt an immediate benefit. His sleepiness resolved. He was able to stay awake for school, and was, like shockingly compliant with his CPAP. So in terms of take-home points for cases 1 to 3, we're looking at the approach to pediatric OSA. So the key is that your history and physical, I've told you, are not very good at diagnosing OSA, but what it is good for is for identifying risk factors and knowing when to pursue further diagnostics. So you want to use your history and physical to identify those children who are at risk for OSA and who would warrant further testing. The polysomnogram of the sleep study is the gold standard for diagnosis of OSA. And then other alternatives like questionnaires, oximetry, simply the history and the exam, they are quite limited in the ability to predict your sleep study findings. But I think as we move forward, increasing accessibility to pediatric sleep studies is important, and then considering alternative approaches in resource-limited settings. So when would an oximetry be appropriate, or when can you use it in lieu of a sleep study based on its results? And for most young children, large tonsils and adenoids will be the major risk factor for OSA, and endotonsillectomy would be first-line therapy if it's moderate or severe. In terms of severe persistent OSA post-endotonsillectomy, or if there's clinical red flags, it's very important to ensure that there's a clear explanation for the ongoing OSA. So we want to make sure that we know why a child is having obstructive sleep apnea and not taking it for granted that it just exists. If there's no clear risk factors for OSA, so the common ones, weight, adenoid regrowth, other airway lesion, craniofacial anomalies, low tone, then you have to consider a central pathology, and you have to rule out all sites of airway obstruction. So essentially scope from nose to cords and consider neuroimaging if that's normal. Adolescents and adults tend to present more with excessive daytime sleepiness than younger children. So that's the third case that we talked about. Younger children tend to be more hyperactive and have difficulties with daytime executive function, attention, focus, concentration, and that sort of thing. In adolescents with moderate to severe OSA in the context of obesity, if there's no large tonsils or adenoids, the initial therapy would be CPAP, and that's quite reasonable. Versus those younger children where tonsils and adenoids are enlarged, if you've got moderate to severe OSA, the first line would be endotonsillectomy. As has been brought up by the audience, compliance with CPAP can be challenging, so it's very important to ensure that both the child and the family are well educated, well supported, and you arrange close follow-up. Contrary to what you might think, teenagers tend to do better when the adult in the home or an adult in the home is engaged with them in terms of CPAP usage and helping them stay compliant. So case 4, we've got a 10-year-old male referred for snoring and possible OSA. 3 to 4 year history of snoring increasing over time, and that corresponds to an increase in weight over the past 3 to 4 years, associated with nocturnal diaphoresis and chronic nasal congestion. No witness pauses in breathing, no nocturnal anaresis, no headaches, and the review is unremarkable. Other than his weight, he's previously healthy, no meds, no allergies, and non-contributory family history. In terms of growth parameters, BMI is quite elevated. He does have grade 3 to 4 tonsils, mild nasal congestion, and reduced flow through both nares, and then the remainder of the exam is unremarkable. The sleep study shows severe central sleep apnea and severe obstructive sleep apnea. So the central index is 50 events per hour, and the obstructive index is 26 events per hour. Periodic breathing for 27% of the total sleep time. Nadir oxygen saturation is 80%, and he didn't tolerate the end-tidal CO2 monitor, so we could not comment on hyperventilation. So he's having severe OSA, and the question is, why is he having severe OSA? And so we talked about it. He's got risk factors for that. His weight is a risk factor, and his end-tidal hypertrophy would be a risk factor. And the question is about the central sleep apnea. Well, why is he having that? And why is this guy talking about central sleep apnea for an obstructive sleep apnea talk? The list is long, and I don't want to go through that list. It's overwhelming, making me anxious just looking at it. But in general, you can break down that big table into these larger groups. So you can have physiologic central sleep apnea. So, at times of sleep-wake transition and post-arousal and post-sigh breath, we all know to be physiologic respiratory events. Central lesions or brainstem compression. So we talked about this with the RLPR malformation. Brainstem tumors, so CNS tumors, can also put you at risk for central sleep apnea. Cardiac conditions. This is not common in children. There's one study looking at cardiomyopathy and an increased incidence of central sleep apnea. But other than that, it's not really well defined and certainly not as common an entity as you see with adults. You can see it in endocrine conditions. So I'm not going to get too deep into this in terms of ROHAD, which is a hyperventilation syndrome. And then genetic conditions, so trisomy 21 or congenital central hyperventilation syndrome, you can see central sleep apnea. And the one I wanted to highlight is central sleep apnea associated with other sleep disorder breathing, so associated with OSA. So for this child, his central index was 50 and his obstructive index was 25. So we did go down the route of further investigations just to be sure we weren't missing something. MRI brain and brainstem were done, it's unremarkable. Echocardiography was unremarkable. Endocrine assessment by way of blood work, and a serum bicarb because of the absence of an assessment of his CO2s was unremarkable. Pulmonary function test, really not much here. A mild reversible obstruction, not great technique. And what we tried was an auto CPAP acclimatization with close follow-up. And this was to see what would happen once we got rid of the obstructive sleep apnea component. With 11, and so he did well with that. The download didn't seem to identify central events, and his AHI on the download was well controlled. And now that we've comfortably ruled out any ominous cause for the combination of obstructive and central sleep apnea, brought him in for CPAP titration, and 11 centimeters of water resulted in optimal control of both the obstructive and central sleep apnea. And so, now we do know what his central sleep apnea was from. And I think it was from his obstructive. So he's having obstructive sleep apnea. What would happen is he would fall asleep. You would see there would be flow limitation, big breath, central apnea, big breath, central apnea. So as soon as he'd fall asleep, he would have this large response. And Dr. Narang, I think, is going to talk about sleep endotypes and loop gain. And so he would have these exaggerated responses to this obstruction, and that would set off a cascade of periodic breathing that accounted for his high central index. And that would happen right when he'd fall asleep. And then he'd have the OSA, and then he'd have an awakening, and then he would have another series of these central events. So when you took away that airway resistance, then these transitional events just disappeared. So he does also have end-tidal hypertrophy. Now, he was compliant with CPAP, but did not want to use it long-term if he didn't have to. And so it's difficult to convince, and reasonably difficult to convince someone to take out the tonsils and adenoids in someone who has central sleep apnea. Do you want me to address them now? Okay. sorry, I've just been given some questions from the comments. So in patients 12 to 18 years of age, pediatric or adult criteria for HI can be used. Sorry, I don't know if that's a question or a comment. Is it OHI at 1.5, still reporting it as normal? Okay. So I think that question is an OHI of 1.5 considered normal? So we're veering a bit from this, but the classification scheme I showed earlier, the less than 2. So historically, the severity classification is somewhat arbitrary, and people have used 1.5 to 5 as being mild, and that's an obstructive apnea-hypopnea index, and they'll use an obstructive apnea index of more than 1 being abnormal or mild range. There was a study called the CHAT study where the definition used for obstructive sleep apnea was an obstructive HI of 2 events per hour or more. And so we essentially just used that definition for classifying mild OSA. So to answer that question, some people still do use 1.5 to 5 as mild. We use 2 to 5. I think the bottom line is if you have an AHI between 1.5 to 2, you can approach that the same as you would 2 to 5. And clinical symptoms would be important to take into consideration in terms of whether you're going to watch and wait or whether you're going to actively pursue treatment. So back to this case, just to refresh everyone's memory and my own, this was a child with high BMI, adenotonsillar hypertrophy, central sleep apnea with a central index of 50 events per hour, obstructive sleep apnea with an obstructive index of 26 events per hour. Did well with CPAP, getting rid of both the obstructive and central sleep apnea, had adenotonsillectomy because although he was compliant, did not want to use CPAP long term. And so he essentially was saying, if there's any chance of not needing to use it, I'd like to take that. And I was saying, it's difficult to convince someone to take out the adenoids and tonsils when your central index is twice as much as your obstructive index. But what that CPAP titration helped demonstrate is that central index was largely driven by the underlying obstructive sleep apnea or the obstructive pathology. And so he ended up having adenotonsillectomy. Post-op sleep study was done. There was no evidence of significant sleep disordered breathing. He did have less REM sleep time on this second study, so maybe it was underestimated. But regardless, he was having non-REM events, and there was some REM sleep, and he did much better. Clinically, he was significantly improved. And a repeat sleep study 1 year post-op, 1 year after this initial post-op study, just because of that reduced REM sleep time, was also normal. And I think this is the last case. So case 5, 16-year-old male with a history of trisomy 21, severe OSA and central sleep apnea that's long-standing, past medical history, had an AVSD, was post-repair, has a history of hearing loss and subluxation of the cervical region. In terms of the sleep study that was done in 2020, I just want to highlight that his events or his obstructive AHI supine was 363. Was 98. That doesn't make sense. Was 98, and his non-supine index. His overall index was 67, and his supine index was 98. We don't have the non-supine index on this frame, but this was back in 2020, and at this time, no one was really thinking about positional therapy in the program. But you can see here, so these lines in between, like the saturation here between these lines, that's not awake. It looks like it's when he's awake, but that's when he's non-supine. And then you can see when he's supine, he's so much worse. So we had a repeat sleep study where this was 2 years later, and he's supine for the first half and then non-supine for the second half. And you can see just how remarkably different those oximetries are. And so his supine index on this next study in 2022 was 113. Non-supine was 0.6. So it's a marked difference. And he had 40% of his total sleep time supine. So we had a good comparator group. This was a child who was, as alluded to earlier, CPAP compliance can be challenging in children. In children with developmental conditions, it can be increasingly challenging. And he was entirely non-compliant with his CPAP, but he was very compliant with positional therapy. And so I've just put up 2 studies here that were done by one of our ex-fellows, who's now in BC, and they were published relatively recently. So one in 2021 and one in 2025, looking at positional therapy in pediatric OSA, and the efficacy of it. And they're small studies, but like I said, it wasn't really on many pediatric sleep physicians' radars, the use of positional therapy until more recently. And so this is a child who had very severe OSA, but because of his positional component, was amenable to positional treatment. And so that's what he ended up doing. He was CPAP non-compliant, but quite compliant with positional therapy. All right, so in terms of the objectives, what we were hoping to achieve was, by way of these cases, and having the audience gather a working knowledge of the nomenclature used in ped sleep medicine, understanding the key elements involved in a sleep step. That's an old objective. That's not relevant to this talk, sorry. The third one, appreciate the clinical presentation of OSA. So I'm hoping that we do that, or we did achieve that with these different cases to highlight just how different it can be in terms of presentation and management. Understanding the basic pathophysiology, so the anatomic considerations and the increased airway collapsibility, and then having an approach to managing children. So, the approach based on severity classification, and then knowing when is first-line surgical treatment relevant and when do you think about CPAP or other advanced options, and also knowing when do you need to look further. So when you've got someone who's got no real explanation, it's important to go ahead and look further for why they might have OSA, and then knowing or having a knowledge of the various therapeutic options and how to select what may be most appropriate. So that's just in terms of medications. We talked about anti-inflammatory therapies. We talked about surgical treatments, PAP therapy, and then advanced surgical options and when they may be relevant. So hopefully we've been able to achieve those objectives. Any questions?